as normal. Oh, good. Okay. But Joan, why don't you go ahead and lead off?
Thank you, Dean Sloan. Sarah, yes, and please feel free to use our first names today. We are so excited to be with all of you to share our experiences, like Sarah talked about, our journeys, if you will, into healthcare social work, and then also to give you just a broad overview, kind of a high end overview of healthcare social work practice that we hope will generate questions. We'll get you thinking about, what you're interested in doing professionally. Might also help you rule out healthcare social work. You might say, "Oh, no, that was the piece of information I needed to tell me that maybe this isn't the area of practice for me too." And for those of you who have taken healthcare social work with me, I say it's great to use these opportunities to rule in or rule out. So we really welcome your questions today. We want this to be interactive. So we wanted to start out, as Sarah said, by just sharing our journeys, our stories, with you, because they're so important, right? In terms of how do we know if an area of practice is really a good fit for us, and what we want you to take away is that there's so many pathways to healthcare social work. There are many pathways to all areas of social work practice, and we have a feeling our stories will really demonstrate that. And we are storytellers, right? And I'm a narrativist for sure. I like to tell stories all the time in class, as those of you who know who've taken class with me. So I'll start out with my journey and then hand it over to Sarah. So, my journey into healthcare social work was one that was highly impacted by my early life experiences. My father died when I was 9 months old of small cell lung cancer. So I was really born into a world of, awareness around grief and loss, expression of grief and loss, and this connection to an experience of really being immersed in the healthcare system. My mother had, just navigated everything while she was also, pregnant with me, and then taking care of a baby. So it was very much part of the milieu of my childhood. When I was 5, my mother was diagnosed with stage 3 breast cancer and successfully lived with cancer as a chronic condition for 17 years. So I sort of grew up in the healthcare system. I spent a lot of time in hospitals, in chemotherapy units, in doctor's offices, just kind of, going along with her to various healthcare spaces, and was very, intrigued, very interested in how it all worked, and how is my mother being supported? How is the system not working for us? So for me, it really goes back to, this interest really goes back to my early life. I saw firsthand, and this gets into the policy pieces, I saw firsthand what living with a threat to your health insurance coverage can do to a family, because we did not have the protections of the Affordable Care Act that we now have. My mother had to constantly worry about whether or not she was going to have healthcare coverage. And that, of course, meant that she had to keep her job, even if maybe she was feeling too sick to work or needed to take a break. She would have faced astronomical increases to her health insurance coverage if she lost that coverage she had. So I have a very acute awareness of what it feels like to live in a family that's under that pressure, and a very clear appreciation for the impact of that policy change, however imperfect it is at this point. When my mom's cancer became life-ending, I was her caregiver as a young woman at the age of 22. So by the time I decided to be a social worker and attend graduate school in our program about 20 years ago, I had a really crystal clear idea about what I wanted to do professionally. I knew I wanted to focus on grief and loss, healthcare, social work practice, and gerontology. My grandmother, because my mother was so sick, had really helped raise me. And so I had a great appreciation for later life and all of the insight and wisdom and growth that can come in that stage of life. So I really was one of those students who knew exactly what they wanted to do. And despite great, mentors of mine telling me, try something different, I was on a very clear pathway. I think trying something different is fabulous, and I encourage all of you to do it. I was not one of those who was willing to do it. So prior to graduate school, I worked at the American Cancer Society as a cancer information specialist. And it only took me about a year on the job to realize that I really needed more training. I was speaking to people who were actively grieving their own losses. They were going through, really complex emotional experiences after a surgery or during their treatment. And I said, well, I have a psychology degree and I have an English degree. I don't know that I am fully prepared for, to meet the needs of, these callers, these clients. It was a phone line that I worked on. And so that's when I decided to go back to graduate school. I promise I'm not going to tell you my whole life story. I'll be wrapping up very soon and kick it over to Sarah. But I, arrived at UT and proclaimed these interests. My first practicum was in a skilled nursing facility, working with older adults, which I absolutely enjoyed. I love the interprofessional work. I love the complexity of the problem solving and how you could weave the care coordination in with the clinical opportunities. My final practicum was in an inpatient psychiatric unit where I worked with exclusively with older adults. And so I was able to really look at, the intersection of neurocognitive disorders and cognitive changes and significant, serious mental health needs, and how to support someone through experiences like that and support their families to find appropriate care and appropriate treatment. So right out of graduate school, I took a job in a very large skilled nursing facility in East Austin, and really 200 beds. When I say large, it was very large. And it was me and one other part-time social worker. And so, the needs were very, very high. I learned, so many complex skills in that setting, suicide risk assessment, complex case coordination, every resource in the Austin area I really needed to know about in that space. And then I was actually recruited, and I always laugh because I tell the story. I answered the phone, and the caller said, we would like to interview you to work at our nursing facility. And I said, are you recruiting me from one nursing facility to another? I really didn't know that happened and that was something that could happen. So I did. I interviewed with the other facility and realized that they had more resources to support their residents, to provide higher quality care, and that I had to look at that self-care piece for me and whether or not I could really continue to provide the level of care and services that I knew was ethical and best practice in the first building. So I did make that change, and for 7 years I worked in a skilled nursing facility that had excellent administration. They really valued the role of the social worker. I was brought into all of the programmatic discussions about how to enhance and improve care. It was a wonderful time for me professionally, and I really, remember it today as really one of my best professional experiences. But as all good things do, it came to an end, and I transitioned into being a therapist using that clinical licensure that I had recently received. And I was a therapist with older adults in assisted living, skilled nursing, and in the broader community. Really, really loved that work. And then transitioned into hospice work, where I provided end of life care that included grief counseling, advanced care planning, and family counseling and planning in that role as well. And then I was hired here at UT. I won't go into everything I've done here at UT because I take another hour, and I don't want to take up too much time. But I will share that I teach our healthcare and social work class, like I mentioned. I've taught that for 4 years. And I also help run simulations with Sarah, healthcare simulations, which I really value. And I encourage you, if you have a chance to participate in one, let us know. We'd love to get you signed up for those. And I'm going to stop now and hand it over to Sarah. Thank you.
Great. Thank you so much, Joan. I mean, we work a lot as partners in the work we do. It's a lot of crossover, so it's always exciting to hear all the things that you've done. So I was trying to think about the best way to talk about what I've done and also to be transparent because sometimes, I mean, Joan's known for a long time and has been affected in her life. I did not know that this would be something that I would be doing out of college. I worked at a camp and conference center. Then I worked for Habitat for Humanity for 10 years, and I'm much older than I look, younger than I look, something, but I've been working for a long time. And so Habitat for Humanity, which builds houses in partnership with people in need. Then I went to graduate school, and my first internship was at an AIDS hospice. And it was a 5-bed hospice. And that's where I got my first taste in social work and healthcare. And it was very comprehensive. There were a few of us. So there were, I mean, and this is really not what you typically do in an internship, but there were some days I was cooking breakfast for the 5 because the person couldn't come and they needed to eat, and all sorts of other more intimate things that you do at bedside when folks can't get up and down, and also having conversations about end of life. And my whole perspective of death and dying changed in that process. So that was my first taste, and I was like, okay. I then was fortunate enough to get a practicum, final practicum internship at CMHC at the Counseling and Mental Health Center. And so I started working for UT around 2004 as a paid person. And I had the opportunity. So I was doing, what we all do. Were trying to get money, we're trying to get our hours, we're trying to get a supervisor. I got all that at CMHC by working there. And then there was an opportunity for a senior social worker in integrated behavioral health. And it was mindfulness based. And I was like, well, this all sounds interesting. And to be honest, it was a way for me to move up. It was a way for me to make more money. It was a way for me to do something new and different. I had an interest in mindfulness, but it really changed my life. And it's kind of fun when it changes my life, and hopefully it changes the clients' lives too. So, what I did, if you've ever gone to UHS for anything, and I know college medical centers get a bad rap, but they're really great doctors. They want to work with college students, they care, they mostly understand. So I was in one of the modules, and I had medical doctors and nurse practitioners and PAs working with me. So we would consult. My sister always told people, like the show ER, I was a psych consult. And that's basically what I was. Someone honestly would be crying in their office and they would send them to me, not always, but a lot. Someone would be having anxiety and they would send them to me. Someone would be having, I mean, honestly, everything from erectile dysfunction, no joke, to I don't know what's wrong with me. I think I'm having a heart attack, when it's anxiety, or just stress had overtaken them, referrals for ADHD and learning differences, all sorts of wonderful things. I loved working with that interprofessional team, and I loved serving as a consult. I also loved that we were using mindfulness based interventions. I was lucky enough for them to send me off to some training, and it personally changed my life because it started me on the path of using mindfulness based interventions and helping clients to also attempt not to be carried away from their thoughts or think of them as facts all the time, because it creates somatic bodily experiences when you're living in a state with things that you don't know are actually going to happen or not. And we all do it. We have this anxiety, and we all have some kind of anxiety about, oh, I wonder what tomorrow will be like. I wonder if this party will be fun. I wonder, blah, blah, blah. And so I learned a lot about it and started practicing, because all the interventions said that the practitioner has to practice mindfulness. I was like, okay. And then it's become a lifelong thing for me. So that's a side note. Um, and then I I'd been there a long time. I probably did that for 3 years, went back up to CMHC there on the top floor, and then got and then applied for this position at the School of Social Work. Now I started out as a practice and practicum instructor. Then there was an opportunity to be the assistant dean for health affairs and to work with Dell Medical School and to work with the social workers at Del Med UTHA. So that's where I am now. I'm the assistant dean for health affairs. I teach the class. Also, I have a great interest in um, all the programs and services that help us to get the health care we need. And I feel very strongly and wish that we had more of a system where nobody had to worry and that we could figure that out. And I mean, in my lifetime, which has been a while, we haven't been able to do that. On a side note, I spent probably from 2005 to 2015 on trying to make sure that same-sex partners got insurance, because for years my wife did not have insurance because it was written in the code of Texas. And so there was a group of us that we talk about it almost every time, like we were in battle together. We talk about when we come together, because we worked, weekly. We tried so many things. And then Obergefell, I don't ever say that right, in 2015 said, "Oh, yay, you all can, it's legal to be married." And that weekend we got insurance. So we'd like to think it was something we had done. We don't think so, but we tried like hell to get them to do it ahead of time in a number of ways. So I just wanted to let you know that I'm very interested. It was a huge moment, Hetty. It really was. It was an exciting moment. They had cupcakes for us over at HR and balloons, and students came, and it was a giant deal. And we all came together to sign up, and it was very emotional. And also we were pissed off because why did it take this long, and why did it take this? And on a more sober note, there were a couple of people who died, who were partners at UT. Their partners died because they didn't have adequate insurance. And we had a report and we laid it out, but that was not what changed. What changed was when the federal government intervened. So it's of interest to me that we should have access, and I'm going to stop there.
Thanks, Sarah. Really appreciate you sharing such powerful experiences and difficult experiences. And I want to lift up as we begin to share our brief PowerPoint, because we really want to get to your questions, that, like all areas of social work practice, the personal and the professional experiences in healthcare social work are so intertwined. And of course, I'm sure you heard that in the introductions that both Sarah and I just made. So, feel free to ask us questions about our own journeys. And if you want to know more about, how do we cope, how do we celebrate the victories, and how do we carry some of the hardships with the folks that we serve in healthcare. All right, so we thought we'd give you a brief overview of healthcare social work practice. We recognize there may be some of you thinking, well, what does it really entail? What opportunities are really out there? What does being a healthcare social worker, really look like in practice? So we're going to really try to keep this concise. You can tell we're storytellers. So please, raise your hand, interrupt, unmute if you have questions as we're going through. We can keep it very informal. All right, so I could not resist. I had to put this in. So and Sarah said I could. This is me beginning as a volunteer in Shreveport, Louisiana. I think I was about 16 there at Highland Hospital. So, sometimes again, we have like a calling or we're driven, and then sometimes we land where we land. And so I just wanted to share that, for me, it comes from something way back when. All right. So we wanted to just kind of talk about the various types of healthcare social workers. The great news is that there are so many opportunities. We are not going to be able to cover all of them today. So this is really, again, just a broad overview. But we'll start with the most acute care setting where you will likely find, you should find healthcare social workers, which are inpatient settings. You're likely to find anywhere from 1 to 3 or 4 social workers in these various inpatient settings, and that's really depends on the number depends on the complexity and the size of the unit. For example, in the emergency room, you often see 2 social workers. I think all of us could envision needing, 4 or 5, but that's, usually the standard there. While these settings, again, could often use more social workers, the great news is that these social workers are part of robust interprofessional teams on these units or in these different sections of inpatient care. If you look, you'll find social workers, throughout settings that where you may receive care or where your family members may be receiving care and friends, like Dell Children's and Ascension Seton and Baylor Scott and White. They're there. Now they're so busy, you might not, know exactly who they are. And they're not always the first medical professional someone sees. Sometimes they might be. But I encourage you, sometimes when I go into healthcare settings, I say, oh, where's your social worker? Or how does your social worker participate in the care? Because I'm curious and I'm collecting data. You can do it, for whatever reason you want to. So if you're interested in areas like substance, misuse treatment, end of life care, grief and loss, work, complex care coordination, you might find yourself, in one of these settings, really interested in working in these spaces. I do want to let you know that inpatient settings usually require kind of the fastest pace of work. So if you're someone who really enjoys moving up and down hallways, this was me. I was like, yes, I'm, going from room to room. I'm at the nurse's station. There's a physicality to the inpatient setting where you're very mobile. Then this may be a great option for you. If you're like, nope, that's too chaotic for me, not really interested in that kind of pace. That's something to be aware of if you're considering an inpatient healthcare social work position. But as you can see, there are a wide range of specialty units where you can really address complex emotional, behavioral, and social needs. So, I will hand it over to Sarah, and I want to make sure that you hear that in inpatient and other settings, you have the opportunity to really look for an area of care that resonates with you for any reason that feels, like a good fit for you. All right, I'm going to hand it over to Sarah for outpatient.
I want to tell a quick story about inpatient. My father-in-law was in inpatient. He had Lewy body dementia, and he was stuck in purgatory, really. He couldn't be home, and they couldn't find a facility that suited the family yet. So he was just in a room with someone, with a sitter. And I didn't think things were going fast enough. And I said, we're valued as social workers. We really are. But the social worker must have been extremely busy. I'm going to give them that. But I made a little call and I said, hi, I'm a social worker and you're a social worker. And I want to thank you in advance for advocating for my father-in-law and getting him what he needs. I know you want to. The family's very concerned, and things changed quickly. And, I don't think we need to threaten anybody, and I certainly didn't, but I was very clear that was reminding her this is what we do and that we've got a lot of people typically behind the person that's being served. So I just wanted to talk about that with inpatient and the way how much you can make a difference. So outpatient, this is healthcare settings that don't require hospitalization. So these are, often you leave an inpatient and then you'll have, regular visits if you're privileged to have those things, but there's all sorts of specialty clinics you can see. And this is Joan's work, and she's always so complete in helping us to understand all the things that you can think about and what's needed. So there's so many, you know, specific places that you could work and things that you could do. And you may find yourself thinking, there's community health centers, there's free clinics, there's People's, there's the Kind Clinic. They're not all free, but they're open to services for folks who don't have resources. There's migrant health clinics. There's a volunteer clinic in town where people volunteer supplies, they volunteer their time. Um, School-based health centers can be really important to children, and of course, family planning and prenatal clinics. And there's also just large physician group practices. They're not, I'm going to be sort of tongue in cheek, they're not always smart enough to get social workers in there, but they should. And a lot of oncology specialty centers are now coming, on to understanding how important we are to be there and help with a number of things. There's also home health where we go out to homes and help, and in-home hospice services where someone chooses to die at home and that we go there. So I'll let you move ahead just in the effort of time. Anything you would add, Joan?
I just would, and thank you so much, Sarah. I would emphasize the advocacy piece around, primary care physician settings, where
Oh,
the
yeah.
large physician groups, we as patients can also inquire and recommend that, these agencies, these settings have social workers, right? We can advocate and say, well, if you're delivering challenging news, which, in most healthcare spaces, right, especially outpatient, inpatient too, but often that's where the challenge or the health issue is first kind of identified, is in those outpatient settings. We need to recognize there's often an element of trauma and or crisis. And wouldn't it be great, right, if a social worker could comfort folks immediately, right, and they could have that support on site. So advocate, ask questions, be curious. All right, so healthcare social workers also serve as public health educators and advocates in nonprofit, government, international and disease-specific agencies such as the Alzheimer's Association, the American Heart Association, a lot of names that you're familiar with, agencies that many have interacted with or come across. As I mentioned, I worked for the American Cancer Society, and provided, various community resources to folks who were just really going through some of the hardest times, in their lives. They were looking for support groups. They were looking for programs to help them secure a wig. Wigs are very expensive. And so, public health, social workers and educators really can make a substantive difference even at the micro level. I will say, though, that you have such an opportunity as a public health social worker to impact policy. And you heard Sarah share a little bit about how she and her friends, impacted policy, were determined to get out there and advocate. And really the education piece is vital. The fact that we as social workers bring the data, we bring the realities to representatives that might not be aware, right? We may be leading campaigns to help them be more aware, right? And so there's so many leadership opportunities baked into being a public health educator and advocate. We think about agencies like AGE of Central Texas, right, where there's vital resources for caregivers available when they may be feeling really lost and adrift after receiving a diagnosis, that they have this one-stop kind of shop where they can, really access a wide range of resources for caregivers. So I'm just sharing that as an example because, you may say, well, being on the floor of a unit doesn't sound very appealing to me, that, for various reasons. There's so many opportunities to impact our healthcare services, our healthcare system, without necessarily being in a setting where, you know, you might be interacting with or seeing bodily fluids, or, you know, maybe some of those less appealing aspects of healthcare social work. As you can see, there's just many, many opportunities here. Sarah, anything else you'd add to this?
No, not at all. Not at all.
Okay, we'll move on then.
So you may be thinking, so what do you actually do? And what I want to say is, as you're learning about what the role of social work is in general, you're engaging, assessing, intervening, and then often helping someone get to the next place. We call it termination, which is sounds a little foreboding, but that you're exiting with them in ways that helps them get to the next place that they need. So you're doing assessments, as you can see. A lot of times we're involved in discharge planning. I'm going to jump to that because nobody wants to be in an inpatient unless they want to be an inpatient. Most people are like, when do I get out of here? My mom's in the hospital right now. She's in a rehab, and she couldn't be happier to find out that next week she gets to go home after a surgery. So that's what she was looking for. And she's going to get all this paperwork. Someone's going to sit with her and help her know what to do so she can continue healing after her events. So we provide education. We do important things. I did a lot when at hospice on advanced care planning, like end of life planning. How do you want the end of your life to be? I also we did care planning meetings with families. Communication is key to understanding how to do family meetings, which often can lead to something conflictual because I don't know about your family, but our families have different ideas about different things. So working with families or chosen families, working with interprofessionally with medical teams is key. And I want to put a plug in for the class FICP, or Transformative Teams, which puts you in teams with medical students, nursing students, and pharmacy students to work, which Joan and I will rush off to after this because it's on a Friday afternoon. We'll both rush off to that. But that's where you learn about each other's discipline and about professional and interprofessional work. It's one of the spaces. The other space you learn it is when you get there and you realize, oh, let's see, who's running the show here, who thinks they're running the show here, and what's really happening. So I'll let you read. You can see, I mean, working with insurance, identifying needs and navigation advocacy, and identifying barriers to treatment, because not everybody, sometimes those treatment plans look a little ridiculous when someone unhoused is sitting there and they don't have money in their pocket to go pick up their prescriptions at Walgreens, and they don't have some of the durable medical supplies they need. So trying to also problem solve in those spaces is really important too. And exciting that we're there and we care about the most vulnerable and oppressed. And so we are there to pay attention to those kinds of things when other people it might not be on their radar. So I'll stop there and you can pick up anything that wasn't covered. Oh yeah, assessing for safe and risk. I'll punt it your way.
Yeah, thanks, Sarah. I just want to also lift up the clinical opportunities that are represented in almost all of the roles that you see here. You're about to hear from us on the next few slides. You're about to hear an emphasis on the clinical opportunities. I hope you heard on the previous slide the emphasis on those meso macro opportunities. There can be this perception that healthcare social work does not really offer robust clinical opportunities. And we're here to tell you that that's just not true at all. When you sit down to talk to someone about whether or not they would like to receive CPR, I guarantee you emotions and attachment issues and fears, all of it's coming, right? Fear is an emotion. Thoughts about the future, all of it, right? Highly clinical, sometimes not. If someone absolutely knows what they want. but often, right, we are sitting with people as they process so much as they navigate the healthcare system. So we'll get into more of that in a few moments. Like Sarah said, I'm not going to read everything to you. There's so much we could tell. We have so many stories, and if you really want to hear them all, please schedule some individual time with us. We love to tell our stories, so
Yeah.
love to share more with you. But I do want to lift up, as Sarah said, the family piece. There's a lot of family work that can go on in healthcare spaces. Now, it's not, long-term family counseling, but you may be sitting down with a family that has fundamental disagreements about how the care should progress. And maybe you're working with a patient who is not able to express their wishes. And so you have, you really have a conflict, and that must be addressed within a family system. You may be engaging in de-escalation with a family that is feeling, or some members of that family system are feeling very dysregulated, very upset about what's going on. So there's a lot of opportunity if you're interested in group work and family work. And then also there's so much opportunity to provide anti-oppressive, affirming care and to be an advocate in spaces where the need for affirming care might not be recognized. Maybe you're picking up on a needs through your assessment that other, well-meaning professionals in that space maybe did not assess for or did not see. And so you're able to be an incredible advocate in those spaces. I remember advocating in the nursing facility for, pronouns to be added to charts, and for residents to be clearly asked which names they wanted on their door, right? And so it can sound simple, but it can be so impactful. And those, those requests, that those points of advocacy often result in a meeting, and where we have to, kind of plead our case as to why this is so important. And so we really use those social work skills to advocate and to make the system more affirming and less oppressive. All right. Anything else, Sarah, on these roles?
I don't think so. I keep watching the time. We never have enough, but I want you all to have a chance to ask questions too. And please pop in or put something in the chat if you have a question. We're going to just talk about a few of there's a lot of therapies and approaches that we use. Assessing for motivations of change through mindfulness, guided imagery, stress reduction. A lot of folks think, yeah, active and reflective listening. I know, emotional support. That's not a theory. If you don't do this part right, they don't want to hear about your theories. This is important to build relationships and that sort of thing. So it's very important. It bears its own slide. We also bear witness to challenges and triumphs that occur with the patient and the family and the caregiver. So these are as important as, named, copyrighted theories that are around. And I'll let you talk about those, Joan.
All right, and we're gonna push through so we can have time
Yeah.
for questions. Again, these are familiar to you, or if you're moving through the program, if you're a newer student, they will be familiar to you. And I want to emphasize there's incredible opportunities to do robust clinical work. I'll give one example and then we'll push forward. But when you think about motivational interviewing, there are so many opportunities to use it. For example, I worked with many patients who did not want to use the assistive device, the walker or the wheelchair, or the hearing aid. They didn't want that change. They were not ready for that change. They didn't ask for it. And so to utilize a modality like motivational interviewing to help them think about, okay, what are the benefits? What could be the benefits of using this walker? And what are the benefits of not using it, right? To really come from a place of non-judgment, and provide that space for them to really look at the options. So that's just one example, because there's so many changes and losses that go on with patients as they are moving through a healthcare experience. And so feel free to reach out and ask us more about these modalities, but I'm going to.
Joan, and also we're still falling under our principle of self-determination. Patients can do whatever they can do what's not good for them. They can go out and smoke a pack of cigarettes when they've got health disease, or they cannot. It's up to them. We don't, it's not on us to have these things stop. So
That's
yeah,
great
well,
segue into this slide. And this,
yeah.
I don't know, your slide or my slide, Sarah?
We said we would both talk about it. I'm just going to say that as you can, all of these things on here, I've dealt with in private practice. I've dealt with in a private setting. I want to just go back to these are very much translated as clinical, skills. I have supervised, I guess, 5 or 6 health social workers, and they didn't all come through the path of the healthcare certificate, and they were school social workers. They were other, and they got interested and got a PRN, which is an as needed job, and learned a lot on the job, got oriented, and but they had been practicing in other spaces where some of these things, like these are a little bit, more where people are like, I don't know if I want to deal with severe mental health issues, or someone who is thinking about suicide or terminal illness, sexual assault, domestic violence, those kinds of things, someone who's living unhoused, tragedies and emergencies. But this is also, especially, I would say, an inpatient, Joe.
Yes, for
But
sure.
outpatient too. Outpatient. I mean, I just am speaking out of both sides of my mouth. I just said in private practice too. Maybe not some of the emergencies. Usually, we know a little bit about what is about to be, happening. Um, but yeah, these are common, relatively common psychosocial challenges that people have to face.
Absolutely. And I appreciate, Sarah, that you shared about the self-determination piece, because sometimes we are the voice of reality in healthcare spaces. Very well-meaning, physicians and nurses who, and by the way, I highly respect those professions and love working with
Yeah.
them, will make recommendations that are correct. They will say, and I'll give you an example of a patient I worked with. This person is unsafe to be going up the stairs on their own. That's correct, right? It's not safe. And the man that I was working with said he knew it, he understood it, he had received the education, understood the education, and he was going to go up his stairs and sleep in his bedroom that he had slept in for 30 years. And that he said, that's what I'm going to do. And if I fall and I die at the bottom of these stairs, that's fine with me. And so I told, the doctor, he's not going to change. This is not something he wants to change. He's received all the education, and we need to respect self-determination. Now, things can get really complicated with competency issues. Is someone competent to make decisions? But if you are someone who really wants to learn complex ethical practice, come on over to Healthcare Social Work, because there's about 300 moving parts sometimes you have to consider before you can make a formal recommendation. So I'll leave it at that. As you can tell, we want to tell all our stories. So we're
So
gonna
what,
oh
oh
yeah,
yeah, you're gonna jump in. Yeah, it's you.
we're gonna wrap up, and I'm gonna talk about what's hard, and then Sarah's gonna end, as she's so good at doing, with the positive aspects. So we want to be very transparent and honest and open that there can be, and there often are, challenges around interprofessional communication. And there's hierarchy in most, if not all, healthcare spaces, where the physician is often seen as really driving all of the care and the direction of the care. And so social work is steadily being integrated, more valued. Even in the 20 years I've been practicing, the value of social work in healthcare has grown astronomically. So I want to, leave that positive message with you. And it's still a factor, right? Where not every other profession is always going to see the value of what you're doing. There's a lot of times when you'll have to explain what you do, right? That we don't just give resources. That's important, but that's not all that we do, right? And we do know so much about policy and regulatory and trauma-informed care, and that they really should be listening to us. Again, most do. And in healthcare social work, you will have to, at times, explain what you do and advocate for your own profession. It's a chaotic environment, right? Sometimes. So teens change, shifts change. You know, maybe you don't, maybe you're the only social worker. I was the only social worker on the hospice team when I worked in hospice. So I had to call folks, I had to consult with others, you know, that were not in the agency and de-identify and make sure that I could do that with confidentiality being held. But you know, there are spaces where you're the only social worker and it's emotionally challenging. You must have a robust self-care plan. How are you going to take care of yourself? I used to take drives and think about my the patients that I had served. And sometimes I'd see buildings, you know, that someone had shared in a social history with me. I'm like, oh, that's where Miss So and So went to church, or and just really spend time reflecting on the beautiful people that I had worked with. That was my way of taking good care of myself. There's frustration with the system. We do not have universal health care in this country, as you all know. We have not, the state of Texas has not expanded Medicaid. So we have millions of people uninsured, and it is an injustice, right? We are really, you know, striving for a better system. We are advocating, we are fighting. And so you have to think about, how will I take care of myself under that kind of oppressive system, right? Where every day can feel like a struggle. There are great days. And so that I'm going to take that over to Sarah. What are the great parts about being?
So it's a chance to connect with clients. It's very tangible because it's a need that's, relatively, somewhat obvious. It's a chance for us to like have someone's back and to make something really difficult manageable and sometimes meaningful, if that's how it works out. And also provide some coping skills that might help mitigate some of the suffering, and to just have collaborative work with dedicated interprofessional teams along the way is also great. The last thing we would say, and I know we press on self-care, and you can go ahead and press this slide because we have a couple of questions, is try to have consistent self-care and embrace that roller coaster that happens. I think something like mindfulness, but you don't have to sit, on a cushion and do that, or movement of some sort of internal process is extremely helpful. And I watch my niece is going to be I'm pointing to where she's living with us. She walks 5 to 6 miles a day because she can, and she's a nurse. And so that's quite a self-care plan, but that helps to mitigate some of the frustration. So I'm not recommending 5 to 6 miles a day, but I'm recommending some sort of practice, and we can talk to you about that, about what those could be. I'm going to jump in on Hetty's question. I'm curious about your experiences of navigating the intersection of social work and medical ethics that you might have felt surprised or wish you had had the chance to think about before faced. I mean, that the first thing that came up is this feeling of moral injury, that you could do something, that the hospital could do something, that somebody could do something, but they don't, because these are not nonprofits. These are for-profit entities. And the fact that you're like, well, you can't let them go. They don't want to go, but they're being discharged because there's no more we can do because they don't have money, insurance, etc. And that's just those are the facts. And I think one of the harder things, you may be told you can't give someone another sandwich, someone who's unhoused, and you may figure out a way to get them a sandwich, or you may be like, oh, those are our rules. It's like, we can't give them another sandwich, or another drink, because, to be frank, a lot of times people who are uninsured use the emergency room, use the hospitals for their primary care. And so the attitudes about that are also, our ethics are to, try to help figure this out, and there's very clear standards on how to do that. So that was my first idea, and we're going to be lucky enough to work together and have conversation. So please reach out and we can talk more about what that feels like. And of course, your practicum instructor, we all feel it, we all talk about it, we all know about it, we're all trying to fight it. we're all trying to do more for the segment of population that doesn't have access. And so I hope we're clear that we understand that there are the haves and have-nots in healthcare. There really are. And we can work in any of those systems to be helpful. I wonder, Joan, if you could take, is it Hallie or Haley? Hallie?
It's
Haley?
Hallie, like Halle Berry.
Ooh, okay. Halle Berry. Can you take Halle Berry's question? Oh, you're muted, unfortunately.
Absolutely. I
Yeah,
would
there you
jump in there, and thank you so much for your question, Hallie. So, caregivers of patients with complex conditions often grapple with the seemingly inappropriate thoughts and feelings they have. And what I mean by seemingly is that society doesn't really have a space, a clear space for them to express anger. If you are, for example, anger, right? If you are the parent of a child with a complex condition, I have a friend who's the parent of a child with a very complex congenital condition, and she feels a lot of anger. And there's just not a lot of spaces where she can say, I'm grieving the, experience that I thought I was going to have as a parent. I'm angry about that. And, that those are just really, really valid feelings that warrant and deserve space to be expressed and fully explored. And so as social workers, we really have an amazing opportunity to, number one, validate that grief is happening, and that it is absolutely not only appropriate, but it is, natural, and probably one of the best mechanisms for moving through a really difficult experience is to allow that grief process, right? And so, eventually we hope to support folks to make meaning for themselves around, what does it mean for me to be a caregiver of someone, for and with someone, care partner with someone living with dementia? What does it mean for us as people in relationship, right? Whether we're, partners, whether we are siblings, what meaning do we make out of this? What impact does this have on our lives, and how do we integrate this experience fully? So I think that really allowing those spaces for the feelings and the experience of grief, wherever you are, if you're working in hospice, if you're working in the emergency room, and really recognizing complicated grief, meaning grief that has many moving parts and is impacted by maybe early trauma, attachment issues, right? And recognizing that's all coming up and likely in those moments. And then anticipatory grief, when people are grieving folks that are still with us, they're still, living and breathing, but they're not here in the same ways. They can't show up in the same ways that they have before. And that is a significant loss. Thank you, Hallie.
Yeah, thank you. That was a really eloquent answer. Yeah, that's awesome.
Thank you for those kind words. It's something, area of practice I absolutely love and feel very passionate.
yeah, I can see that. I know that. Yeah, that's great.
And yeah, come talk to us if you want to hear more. And I could probably talk for 3 hours about questions. Did we miss any questions?
I don't see any other questions, but I have a question for you all. I wanted to get like a little, or can you speak to like navigating through the hierarchies of healthcare? And because it is very it like working with doctors and nurses and it, all the different staff in a hospital is very specific. So can you speak to that?
I think,
Sarah.
yeah, I know. I mean, that's where we're going next, is to
Yes,
teach
yes.
the class on transformative teams, where we're really trying to understand, like, I cannot do surgery, but I can diagnose, I can assess, I can engage. And a lot of times our healthcare partners, they don't even know that we can do that. I can't prescribe medication, but pharmacy can work with that. Medical doctors can work with that. Sometimes higher level advanced practice nurses can. We need to know we need to use our engagement skills with our interprofessional team, and not be sort of petrified, meaning that we get paralyzed by, oh, that's the doctor. Oh, that's Dr. So-and-so. He is in charge of all children's cardiac. He's the most well known in the world, and it's like, and he also puts his pants on like we do. He also is a human. And I think, sometimes that folks who are in certain positions who are life-saving, and we are life-saving, by the way, too. We catch crises. We're the ones who know how to talk about it. A lot of times people get sent to us, we get sent to people. So we just have to, I think what our partners out there want from our students and eventually their employees is confidence, but not overconfidence. Of course, know what you know and lead with it, and learn what you don't as you build your skills and your knowledge base. And Joan, what would you say?
Well, I know we're out of time. I just to add to your great description there. Curiosity is such a great tool
Yeah.
in healthcare social work practice. And I'll give you a quick example of working with a patient who was living with dementia, but also living with schizophrenia, lifelong schizophrenia. And I was able to, through observation, spending time with her, realize that she really needed to be treated for the schizophrenia, but her symptoms were being all lumped into the dementia diagnosis. And I said, I think there's some level of suffering that is related to her schizophrenia diagnosis. And can we I'm curious about whether she might need to have her medications added on. Is that something we might, look at? And sure enough, she did receive relief from having those medications reintroduced. So, trust your assessment skills. I'm not an expert in.
You're not going to walk in and say, you need to change your medication. You're curious. You've seen other patients where this worked, or
Yes.
you're curious. Same. I would have medical providers say, what do you think we should give for anxiety? And I could say, I've seen this work. This looks like that, but I'm not prescribing. But we became partners because we had relationships with one another. And I think we can end with that. Relationships. And if they don't want to have relationships, we're going to still try to have relationships. We're going to keep working at it. Yeah. Yeah.
Absolutely. Come see us. I mean, as you can tell, we really could talk for hours, and we would
Yes.
love to.
And we love talking to students. So reach out, and so happy. We've been trying to plan this for over a year for us to come and all be together. So thank you for showing up on a Friday morning. And yeah, that's all.
Thank you both so much.
Sure.
Yeah, everyone have a great rest of your Friday and a great weekend.
Absolutely. Okay, take care, Joan. I'll see you soon.
Okay, bye-bye.
Bye.